Hello and welcome to a new episode of Home Medicine Podcast in association with the Royal College of Physicians, Edinburgh. My name is Ben Lovell. I'm a consultant in acute medicine and I'm here with my podcast host.
Hi, I'm Dr. Amie Burbridge, a consultant in acute and general medicine in the UK.
So Amie, it's my turn and I've got a case for you. Are you ready?
Okay, absolutely.
Okay. Emergency department. You're on the take. New referral from ED. 42-year-old man collapsed whilst out jogging. Apparently, according to bystanders, he just hit the ground, lost consciousness for less than a minute and recovered spontaneously and seemed a bit groggy. But by the time the paramedics arrived, he was oriented and alert, although he did look quite pale and clammy. And he told the paramedics he'd been a bit ill with a flu-like illness for a couple of days, but is otherwise in very good health. And he was transferred into the ED, where he was found to be slightly hypotensive at 95/60, heart rate 110 regular, afebrile, normal saturations, normal respiratory rate. Initial reactions, please.
My initial reaction is, why has this gentleman been brought to hospital? He was going for a run. He's clearly had a vasovagal. He probably hadn't eaten breakfast. And I'm happy to give him a cup of tea and a Coke and send him home. However, that is not the right thing. So that's, that's my type 1 thinking at play there. But my type 2 thinking is going, 42-year-old man, collapsed whilst jogging, loss of consciousness. Could it be vasovagal? Did he have a low blood sugar? Could it be a cardiac arrhythmia? Exercise-induced cardiac arrhythmia. Did he have a flu-like illness? Has he gone out to exercise too soon and just felt very weak and unwell? Other things that cause sudden loss of consciousness, I'm thinking really serious. Could this be a pulmonary embolism? Could this be a hemorrhage, brain hemorrhage? That's where my brain is at the moment.
Fine. So you've named, I think, 3 systems there, neuro, cardio and respiratory, which is absolutely fine. And then we'll home in as the story progresses. For me, I don't like exertional syncope. I don't like it in my bones. It makes me nervous. People who are standing around all day and their blood all pools to their legs, and they're the vasovagalers for me when they get us. But I don't like people who are lose consciousness when exertion. It makes me anxious for cardiac problems, especially when they're a bit tacky afterwards. Although the spontaneous recovery very quickly, the lack of a postictal phase, it sounds like, and looking pale and clammy, that could be vagal, couldn't it? But I thought it smelled a bit cardiac. Although, what do I mean by cardiac? By smells cardiac? You mentioned arrhythmias.
Smells cardiac.
Yeah.
So I guess I'm thinking, is this a electrical problem in the heart? Is this a structural problem in the heart? Is it a flow problem with the heart? So electrical problem, I'd be thinking, is it an arrhythmia? So have we got a problem with the AV node, the SA node? Have we got a bundle branch block? Have we got one of those weird syndromes, Brugada syndrome, that you occasionally see? Then I'm thinking, is this a structural abnormality of the heart? So is he known to have a dilated cardiomyopathy? Is he known to have a structural abnormality from birth that hasn't been picked up, although it is quite late, I guess, for that? Has he got left ventricular outflow tract obstruction, which can also contribute to these type of symptoms, particularly on exercise and exertion? And the final one, is this a blood flow? So is this a coronary artery blockage that would indicate myocardial infarction? Potentially. So that's where my thought process is going at the moment. As well as that, you can also have things like infections and toxins that may be affecting the heart, but that's more like an indirect effect on the heart than a direct.
Yeah, I agree. And thinking about just going through what you mentioned, arrhythmias, why would a 42-year-old suddenly have, what kind of arrhythmia would fell you in your tracks when you're jogging and you're 42? It'll be something super fast or super slow. So the super fast one, which we all would fear the most, would be VT. So did he have an episode of ventricular tachycardia and down he went? just de novo. If you had a bit of AF, fibrillation or flutter, in my experience, that doesn't cause syncope. Very rarely in younger people who are able to compensate for it, because going up to a rate of 140, 150, 160, even if you had a burst of SVT, which can go up to sort of 180, 190, just in my experience, tends not to make people suddenly lose consciousness. They tend to just compensate okay. But VT, absolutely.
Yeah.
Or did he go too slow? So did he go too slow and have a Brady episode? Did he have a AV nodal block, like you say? So his sinus node is firing away and his ventricles don't know what's going on and they just don't pump enough? Or did he have a sinus node problem and he just wasn't generating a rapid enough heartbeat for any particular reason? So yeah, arrhythmogenic collapse would be something I'd be really worried about. And you mentioned flow as well, left ventricular outflow obstruction. I do think about exertional syncope. I think about HOCM, so hyperobstructive LVOT block. And usually, I mean, people can present later in life. People who've got familial HOCM, so hyperobstructive cardiomyopathy, they can usually get picked up in screening when they're children because they had a relative, because there are screening programs. But sporadic HOCM can present in your 40s, 50s, 60s when you've developed enough anterior systolic motion of the mitral valve, or that horrible asymmetrical hypertrophy they get, which blocks the LVOT. And maybe it just hit critical narrowness, and then down he went when he was trying to mount a good blood pressure to support him running as it is jogging. So yeah, I had the two same thoughts. PE, I think, is a good thought. I've seen P present with syncope
Absolutely.
quite a few times. Yeah.
Yeah. And it's not something years ago when somebody had syncope. PE wasn't in my mind, and now anybody who comes with syncope, I'm like, is this a PE? Why isn't it a PE? I've seen quite a few actually, so it's always there at the forefront of my mind. Absolutely. Was he a new exerciser, or is he always exercised?
I'll tell you, but first I want to know why you're asking.
Well, I'd be more worried if he was if he's always exercised, because if he's always exercised, it means that his body's probably used to it, exertion, and it would make HOCM and LVOT less likely, because as you discussed before, you tend to pick that up earlier. But if he's a new exerciser, then I'd be like, okay, well, actually, I've seen this happen before. Somebody's gone to the gym, they've gone wild, and they haven't exercised for 25 years.
And I guess if he'd never run before, and if he tries running for the first time, it could unmask.
Yeah.
For example, which he'd never noticed before, because he's never put his heart under that much strain purpose before. That would be an interesting thought. Okay. He actually was a regular jogger. It was something he's quite fit and active person. So we talked about cardio and we talked about respiratory things. And then you briefly mentioned, did something happen intracranially? I guess so. I guess I least prefer that, because why did he recover?
With the speed.
Yeah. If he'd had a hemorrhage, for example, he should still be quite unwell if it was enough to knock his GCS down a few points. All right, then. So that's your initial reaction. I was just interested to hear. And I wrote down smells cardiac, arrhythmia versus obstruction. So we had the similar sort of mind lines there. His history was that this has never happened before. And when I said to him, did you get any warning? Did you get chest pain, palpitations, thinking about an arrhythmia? He says, no warning, just he was running, and then the next thing he's coming around on the floor. And that's never happened before. Usually very fit and well, an active guy with actually no past medical history and no regular medications on board. And socially exercised a lot. It was a non-smoker, very little alcohol. So I thought that was interesting as well.
Could it have been a seizure?
Okay.
I think the recovery's too quick.
Yeah, he didn't seem to have a post-ictus,
Yeah.
according to the witness history. But exercise-induced seizure, I mean, yeah, I think I have seen that before. And it isn't completely off the table. Whenever I see patients, a lot of people I see on the ECU, the Enhanced Care Unit, which is our area of AMU, you've come in with collapse, with transient loss of consciousness, or a T-lock, as the kids call it. I often do say to them on my ward round, so what we're going to do, we always try to work out is when people lose consciousness, is it head or heart? head or heart. And they're the two main things. And of course, that's not quite true because then we always mentioned PE just then. But we're trying to work out if something happened in your brain or something happened in your heart. And that's how I frame it for patients. Quite a nice way of understanding why I'm doing the test that I'm doing. So, I saw him in ED and now I need to make not only a diagnosis, but a plan. So what would you like to do next?
Okay, so I'd like to do a clinical examination. So heart sounds.
Great. Heart sounds, no murmurs.
Okay.
No radial and no radiofemoral delay. Do you remember the moment you get for hokum? I remember learning it for paces.
God, you're going to know this and I'm not. Is it a pansystolic murmur?
Yes, it's systolic. But do you remember how you accentuate it and everything like that? No, you don't.
No, I should.
You must have done this when we were getting ready for paces.
Absolutely. It was a long time ago when I did paces.
So it's a systolic murmur, a harsh systolic murmur.
Harsh systolic murmur.
Increases when they do Valsalva.
Yes.
Because it increases the venous return and also increases on standing up and is quieter on lying down. And I remember being taught on a paces course that was saying, so if you think someone's got hokum, you make them squat on the floor.
Yes. I remember.
You listen to their murmur and then you get them to stand up with your stethoscope still in situ and listen. Never in my life have I done that in front of real creeps. So it hurts me. Yeah.
That's because you're getting old.
I know. And I'd have to squat with them, wouldn't I? So that's off the table. But this made me, I'm going to go, oh God, that's an old flash back memory there from the past. So anywho, didn't have a murmur. So that's
okay.
So she had chest was clear. Chest was clear. No pedal edema. He had a blood pressure of 110/70.
Did you do it on both arms, the blood pressure?
I didn't. Why? What are you thinking? Coarctation of the aorta or something? I did not, I confess. I did a heart rate which was 80 and regular. And his stats were 97, 90 and remain. He was afebrile with a normal respiratory rate. It's not a very revealing examination, actually.
Okie doke. So what
do you want?
I want an ECG.
Okay, good. So heart or head? Let's look at the heart first or...
Let's look at the heart, yeah.
Yeah. Sinus tachy at the time of recording, about 102, so not great tachy, with some very non-specific T-wave flattening in the lateral leads.
Okay. Doesn't really tell me much, I guess. Maybe a bit of ischemia, possibly I don't know. It's not very specific.
Exactly.
I'd certainly want to have a little more of a look into the heart potentially. Has he had any previous ECGs? It doesn't sound like he has.
No.
I'd probably want to put him on a monitor at this point because with these arrhythmias, sometimes they can obviously go into arrhythmia and come out of the arrhythmia. So that might be an idea because he was hypotensive as well, wasn't he?
On the scene, yeah.
Yeah.
60, yeah.
Glucose?
Okay, glucose was normal.
Okay, blood test. So full blood count, USNEs, LFPs.
Yep. Full blood count was normal across the board.
Yeah.
Urea, creatinine, sodium, potassium, normal. CRP, 4. Any other blood tests you might want?
CK?
CK was 4,100.
Wow.
Our upper limit of normal is 500. So it was up. But let's just contextualize this. He was jogging.
I wonder if my CK goes up that much.
It will. Have you never had people? Oh, well, because I work in London, so we get some people who come in after the London Marathon, and their CKs blow your mind and makes your head stand on end. They're like 5 figures. But that's a normal finding after you've done marathon. So I bet yours does go up a little bit.
Oh, okay. So
Highball, what's the highest CK you've ever seen?
Oh, like 150,000.
Okay. I once saw 500,000. But the diagnosis is a patient with polymyositis. So that it was inflammatory, rather than sort of a muscle it was a muscle destruction.
Gosh.
I remember that very clearly. I was like, I've got a patient with a CK of 500,000, and they went to ITU. I was an SHO in neurology at the time, and they were accepted at ITU for ventilatory support. And I can't remember why, but for some reason, me and the neurology reg, were going with the patient as they were being wheeled by the porters from the neurology ward to ITU. And I just remember, it's one of those things that stay in your memory forever. The neurology reg said to me, Ben, out of the patient's issue, and if he arrests on the way to ITU, we just run, okay? Don't stop and do CPR. We just run to ITU and push as fast as we can.
Yeah.
And it stuck with me because I remember thinking to myself, oh my gosh, this is the most terrifying thing anyone's ever said to me. Do you think that's going to happen? But also it was quite exciting, but terrifying. Anyway, that memory stuck in my mind, that 500,000 CK. Anyway, you're about to say something really intelligent about this man's blood results, I could tell.
Highly unlikely. Would you do a troponin?
Would I? Well, someone had already done one.
Okay.
So we're still going heads or heart, and we want to admit him to telemetry bed, right? Because we're looking for arrhythmia. Shall we look for myonecrosis? Shall we look for heart muscle damage? Got an elevated CK, which we say, oh, maybe this is running. But of course, you get a CK release with myonecrosis as well.
So
Now, his troponin was 80, and the upper limit of normal for us is 14.14.
oh right, so it is high.
Yeah.
Okay. Did you do a calcium magnesium level?
We didn't do a magnesium. We did have a calcium, which was normal.
Okay.
What are you thinking of there?
No, I was thinking of calcium because some calcium abnormalities can cause cardiac arrhythmias. Is he hypocalcemic or hypercalcemic?
Yeah.
And I was just thinking, has he become really, really hypocalcemic, gone into SARS de poids, VF, and then collapsed?
Oh, that's a good point, actually. And I should have mentioned when I talked about his ECG that he had a normal QT, QTT.
Okay,
Yeah.
excellent. Okay. And then magnesium, again, low magnesium levels can contribute towards cardiac arrhythmias. I'm stuck, Ben. If I'm being honest, we've got our routine blood test, we've done a glucose, we've done USANEs, LFTs, magnesium, calcium, CK, TROP-T. Ooh, would you do a D-dimer?
No, I didn't. I actually didn't do one
Okay.
because you're thinking about P. Why would
I'm not.
hey, D-dimers, why did you sound so excited about?
It's just wondering whether you'd done one or not. No, I wouldn't. I wouldn't have done a D-dimer in this gentleman, to be honest.
I didn't do a D-dimer because I thought the pre-test probability was low. I mean, maybe I should have done, because of course, if he'd had a massive P, that would have caused heart strain, and that would have caused that slight troponin rise as well, wouldn't it? So maybe in retrospect, a D-dimer would, in this instance, have been useful. At this point, I'm not going to ask you for a diagnosis, which is fine, but what's your plan?
Now, I've got like two things on my shoulders. One's going discharge. And discharge, watch and wait, consider a 48-hour, 72-hour Holt monitor. That's my one brain. And my other brain is, but why is the trop high? Why is the CK high? This is odd. He's got some T-wave flattening. So I think in reality, I'm going to admit.
Yep.
I'm going to put him on a monitor.
Yeah.
I'm going to keep an eye on his ECG. I'm going to get some 12-lead ECGs as well.
Yeah.
I'm probably going to have a chat to the cardiology reg and say, look, can I just run this past you? I'm struggling to really get to grips with what's going on here. Do I scan his head? I'm going to scan his head, Ben.
Okay. So your plan as the post-sick warden, let's be clear, is admit to a telemetry bed for monitoring.
Yeah.
2, discuss with cardio. 3, CT head.
That's my plan.
Okay. I admitted him. I admit unexplained T-logs. I just do for telemetry, which is an investigation, by the way, no test. And I don't admit all T-logs if I can explain it. For example, if someone has a lying standing blood pressure and there's a drop and they had a postural and I think they're safe, I'll discharge them. If someone has, I don't know, an episode in keeping with a non-epileptic event, then I won't admit them for T-log. But unexplained T-logs I do, because I just worry about cardiac arrhythmias and I want to make sure they don't have anything that I could unmask on an overnight monitoring. That's the truth there. So I admitted him. The troponin I couldn't quite explain.
No.
He doesn't have a textbook history for an ACS, right? He didn't say he didn't have chest pain. He just went down. But I was a bit worried that there had been some kind of atypical presentation of some kind of acute coronary syndrome. His ECG is not normal. His troponin's not normal. So from that, I made a decision to treat him empirically overnight with ACS treatment, which is aspirin, clopidogrel, and fondaparinux. Put him on a monitored bed, cardiology review in the morning, and I requested an echo because I want to structurally look at the heart. I know from experience cardiology like to have an echo when they review patients. The echo request I made was any transient loss of consciousness in a healthy young man on exertion, query structural abnormalities, and also elevated troponin with lateral T-wave depression, query regional wall motion abnormalities. Did he have an infarct? Has he got a regional wall motion problem now? He's got a hypokinetic lateral wall or something that might indicate an infarct. So I admitted him for those things. And I said, let's repeat his troponin. Trends are interesting.
Yeah, absolutely.
Troponins, they can travel in different directions. So that was my plan. And in the morning, I came in. The doctor who'd been attending overnight said the patient had a little bit of intermittent but very non-severe chest tightness at rest, which they treated with some GTN. And they did some serial ECGs overnight, and he had some very new mild ST depression laterally. So, and they repeated his troponin, and it went from 80 to 7,649.
Wow.
Which is obviously a high. And then he had his echo, and it showed he had globally reduced LV function with an ejection fraction of 40%. And there was no regional wall motion abnormality to indicate he'd knocked out a wall within infarcting territory. It was globally the LV looked sluggish. So a massive 4-digit troponin number, new finding of LV dysfunction with global reduction in motion in a healthy young patient. This pushed a new diagnosis to the top of my differential now. Oh, with a preceding 2-day viral illness.
Pericarditis?
Pericarditis.
Myocarditis.
Yes. I choked on my own language, my own words there. I said this has got to be myocarditis, viral myocarditis. He's whenever you see a trop rise in the thousands, to me, you don't see that with an infarct. You see that when the whole myocardium is inflamed and is releasing troponin. So whenever I see troponin north of 1,000, that always makes you go, "Ooh, could this be an inflammatory process? This is myocarditis." And that would also explain his reduced LV function. It would explain the troponin. It probably would explain his T-lock. If he had an ejection fraction of 40% and he was pushing himself, he just did not create enough of a cardiac output to produce his pain. And down he went, lights go out. Myocarditis tends not to hurt. Because the nociceptors in the heart are primarily in the pericardium, and coronary vessels. I mean, the myocardium does have some pain receptors, but they tend to mostly detect ischemia rather than inflammation. So the fact he was having some pain now, I thought probably the pericardium is involved as well. So I pushed it all together and I said likely viral myopericarditis. And I thought that fitted together very nicely. And of course, if you want to diagnose this, you've got to do a cardiac MRI.
Yeah. Did you do one?
Yeah, he went for a CMR, and the CMR confirmed the diagnosis of of myopericarditis.
And did you try and isolate the virus that had caused it?
I didn't, and I did say to the cardiologist, "Do you routinely screen for Coxsackie virus?" And he says, "Honest, we don't. It doesn't change anything for the patient. There's no role for immunosuppression or antiviral treatment. So actually, whilst it might be intriguing to know the core virus, it actually doesn't matter for the patient trajectory."
Okay. So when you first started talking about this case, I'll show you because I have written it. I don't need to think I'm just totally making things up.
I was like on Countdown where they share their answers with someone else.
I've written COVID.
Oh, yeah, you did.
Did he
Gosh, is
ever?
that how you think? Show me that bit of paper again. That is crazy. The way you use write things in random patches of the paper. You don't go left to right or top to bottom. This is the representation of your mind. What a fascinating insight.
Nobody wants to be in my mind. But it's weird because my desk is the same and my office and everything, and I know where everything is. But yeah, so I initially thought, could this be COVID, virus? And then because I had a similar episode when I did something, passed out running, but I had COVID. Anyway, so this gentleman then had a viral myopericarditis.
Yes.
What was the management plan and follow-up for this gentleman?
I'm glad you asked. So, viral myocarditis, they do like to keep them as an inpatient until the trop starts to fall,
Okay.
because a rising trop puts them more at risk for fulminant myocarditis, minor necrosis, fatal arrhythmias such as VT, which is much more likely when you've got structural problems with the myocardium or scar. So you keep them in until their trop turns the corner and starts to fall again. And in the acute phase, there's actually really good evidence for beta blockers and ACE inhibitors, or ARBs, but anything that blocks angiotensin, because just like with normal heart failure, it helps protect the patient from cardiac remodeling. And promotes the healing process. So you start them on something like ramipril and a bit of bisoprolol, and that actually vastly improves their prognosis. So we started on both those medications for him. There's really important, you have to avoid NSAIDs, which is sort of counterintuitive, because you imagine if there's inflammation, NSAIDs are the exact right thing to give, a bit of ibuprofen or a bit of naproxen or something like that. But in fact, NSAIDs have been shown A, to be ineffective for the inflammation of the heart muscle, and B, can actually increase the area of the myocarditis and increase mortality. So you don't go near them. I thought that was a really interesting learning point for me, because common sense says, oh, inflammation, let's switch that off with an anti-inflammatory drug. And with the pain, because I suspected there was pericardial involvement, there's really good evidence for colchicine. Yes, on colchicine as well. Yes, for my little applause.
Anybody would think we've been doing this podcast together for a few years, Ben.
The colchicine, it doesn't really have much evidence for myocarditis, but it's very good for the pericardium, and it prevents recurrent pericarditis down the line. And actually, you have to be on colchicine for 3 months, which is a long time. And you have to tell the patient, don't stop taking it just because you feel better. It's a bit like what we say with antibiotics, finish the course, because even though the pain's gone, it helps your prognosis that you don't develop a bout of future pericarditis. So you take 3 months of colchicine if there is pericardial involvement as well.
And do you give 500 micrograms a day of that, of colchicine?
BD, 500 BD, yeah. The commonest side effect that people really struggle with colchicine, as you know, is diarrhea. So you warn them about that, but most people get away with it. And actually, the prognosis is good with that therapy. Most patients have either a full or a partial clinical recovery and can stop beta blockade and angiotensin blockade further down the line.
Just a random piece of history, but colchicine is one of the oldest medications ever that we've used. Yeah, and it comes from the autumn crocus. So, so around this time of year, in fact, although it's very warm, you're probably not going to see them yet, but you have like those small little crocuses that pop up. They've got a beautiful purple flowers, and on the inside they've got the orange stems, and that's actually where you get saffron from, is also from the same plant. So you get saffron and colchicine from the same plant. Isn't that crazy? And colchicine was originally used as a purgative. So it didn't matter what you had wrong with you. This is thousands of years ago. You would get colchicine because it would purge. So you'd either vomit or you would pass feces.
Or you'd improve from viral pericarditis.
Exactly. And also, the way that it works, because it's, yes, it is an anti-inflammatory, but it also works on the cell cycle itself. So going back to DNA replication, is that it does actually affect DNA replication and therefore reduces inflammation.
Brilliant. I love that. A little fact for the day.
Random fact of the day, yeah.
Yeah. So I thought that was a nice
brilliant case, yeah.
Head versus heart. It's nice to do a little bit of CPD about myocarditis. And I do see it sort of once or twice a year. And this was a patient who actually, although had a slightly atypical presentation, all his results were very typical for this particular condition.
Thank you so much, Ben. That was a really, really interesting case. And actually, highlights the beauty again of acute and general medicine. You've got a gentleman, 42-year-old, collapse, the CK and the raised truck T, where do we go from there? Actually, when you listen to the history, when you take the history, the diagnosis is almost there, isn't it? When you put with the ECG and the troponin, you can go, okay, yeah, absolutely. Brilliant. So my key takeaways are viral myopericarditis, use an ACE inhibitor, use a beta blocker, and colchicine.
There you go. Thank you.
Brilliant.
Thank you. I hope you enjoyed that. I hope people listening at home enjoyed that as well. That is the end of another episode of Home of Medicine podcast. We love doing this podcast and we love it when we get feedback. So please do send us a message. Our emails are very findable, and you are very welcome to recommend this podcast to anyone else you think might enjoy it as well. We're not super experts in podcasting algorithms, but we are told that the more sort of ratings we get and comments we get, the higher the podcast comes when people look for good medical podcasts. And we just want to reach more and more people. And we do this for the love of it. So please do pass us on to acquaintances who may get something out of it. And please do leave us a review or a comment wherever you're listening to this if you have the time. Thank you so much. And thank you again, Amie.
Thank you very much. Thanks for listening. Goodbye.